What's the general length of your bypass time on a pump?
So for an aortic valve, the cross clamp time when the heart is arrested for me is usually about 40 minutes, 45 minutes. And the heart-lung machine is usually about 2 hours. And then if we have to do bypasses or another valve or that sort of thing, then it kind of adds on after that. Average heart operation is about 4 or 5 hours altogether by the time we open and close. Yes.
If they're not on Coumadin with this heart valve, they are on Plavix or other medication?
Not necessarily.
You don't have to be on it?
No, if they have a pig valve in, we use aspirin because aspirin does decrease clot. So everybody's on either Coumadin or aspirin, but Plavix is really only necessary for stents. If you have stents in as well, then Plavix is necessary for a period of time, depending on which stents. Then it's drug-eluting stents versus bare metal stents that don't have drug on them. But for the valve itself, Plavix has never really been shown to help.
So if you have stents, then you have to be on Plavix forever?
It depends on the stent and it depends on how long it's been in. So the current recommendations these days are anybody who gets any stent, they like to put on Plavix for 1 month. If it's a drug-eluting stent, which are the ones that have drugs that are given off for over a year, then they like to keep them on Plavix usually for a year after that. That's a current recommendation, but that's a little bit of a moving target as well. We don't do stents as surgeons. The cardiologists put the stents in, but we deal with Plavix all the time. So Plavix is a wonderful drug in that it inhibits clot formation, but Plavix and surgeons don't go well together because it really causes a lot of bleeding. We have to do an emergency operation and that sort of thing. So I talked a little bit about mechanical valves, very rare for structural deterioration. Biological valves don't require Coumadin, but they can wear out over time. If you look at the number of valves that are done of the different type, it's changed over the years. It used to be more than half the valves were mechanical valves. Now, this is tissue replacements, these are mechanical replacements, and this is just in 1 month. This is 200 or 300 per month, and this is 800 per month of the tissue valves. So tissue valves are more than twice as common these days as mechanical valves are. And these are repairs down here. That's where the valves are replaced. So this is the mitral valve. So far we've been just looking mainly at the aortic valve. This is the mitral valve. Mitral valve is a bileaflet valve, and this is what a normal mitral valve looks like. It opens and it flutters a little bit, but it has good coaptation, and that's what a normal mitral valve is supposed to look like. When people have mitral valve prolapse, those leaflets don't come together properly. And most of the time, I mentioned before, we can repair the mitral valve. There are several techniques we can use to cut extra tissue out and put sutures in there, or put a ring in there. Down here at the bottom is a ring which takes that dilated mitral valve and make it smaller again so that it's more competent. And this is an example of a repaired mitral valve. So this is a ring around the edge of it. And it takes the leaflets, which after time can become stretched, and brings them closer together, and it allows them to go out that way. So that's also called mitral annuloplasty, because this is around the annulus of the mitral valve. So there are some other alternatives to traditional valve surgery. One of those is the minimally invasive, and I don't have a lot of good pictures of that today, but that's when we make smaller incisions. There are some patients who are really too high risk for traditional surgery or too high risk for minimally invasive as well. And there's some research going on now to explore less invasive options. Those things include valvuloplasty, which is where we just put a balloon through the valve and sort of break the aortic valve open. And that we're doing now here. We've been doing that for a couple of months now at St. Joe's. Or transcatheter valve. That's where we replace the valve over a wire. Transcatheter valves are not yet approved in the United States. They're under experimental development right now. But we have started doing valvuloplasty in anticipation of doing these transcatheter valves in the next year or two, because there are some studies going on, and I think we'll probably be involved in those here.
Where's the original work for that?
Most of it in Germany. Yeah. There is one system that is approved for use in Canada right now. They haven't put a whole lot of them in, but there's There's a center in Vancouver that's done more than anybody in Canada.
Hmm.
So they actually do have some there. Some of these surgical techniques have been adapted from treatment of thoracic aneurysms. This is something we have a real interest in and have done for a while here. So aneurysms are a ballooning of the blood vessels, where a blood vessel is supposed to be normal and thin. If it's ballooned out, that's an aneurysm. Thoracic aortic aneurysms are those inside the chest, beyond the heart, where the aorta tends to dilate here. That's what a thoracic aortic aneurysm looks like. To fix this, the way we used to do it all the time was we brought the patient to the operating room and made a giant incision across the abdomen and across the chest and kind of stretch things open, expose the aorta, put a clamp here and a clamp here with them on the heart-lung machine, cut that out and sew a valve in its place. That's a traditional means of fixing that. For several years now, we've been fixing them from an endovascular standpoint. And I'll apologize, this is a vendor's video, but they did a lot nicer job than I could do putting this together. This is the way we fix them these days, almost all the time, from an endovascular standpoint on a wire. And this is going to have some applicability to the valve surgery. So that's the aneurysm that I showed you. Aneurysm's got a whole bunch of clot in it. We take a wire up under X-ray guidance, and then there's a giant stent that's on the wire that we then deploy inside the aorta. And what this does is decrease the pressure in the aneurysm here by having no blood flow in it. So we don't take the aneurysm out, but there's no blood flow in it, so it won't rupture. This is what it looks like inside there. And this is a graft made from, this one, it happens to be a Gore-Tex graft, but there are some other impermeable things that are used. So that's how we deploy it. Then we put a balloon in here, and we stretch it out. And this is the way we fix most aneurysms these days. We also fix abdominal aortic aneurysms like this these days. We did one this morning. It took about 2 hours to do, to fix the aneurysm, whereas it used to be we made a big giant incision across the abdomen and the patient was in the hospital for 2 weeks. So the guy we did today will probably go home tomorrow. So this endovascular treatment of aneurysms has revolutionized the treatment of aneurysms. And these same technologies are now being used to develop valves,
How do you diagnose that aneurysm?
usually on a CAT scan.
What would the symptoms be from the...
A lot of times people don't have symptoms with aneurysms. The majority of aneurysms we find are incidental findings. They got a chest x-ray for another reason, a cough or just a routine chest x-ray and we see a bubble over there, or they had a CAT scan or an ultrasound of the abdomen for other reasons, and we just find the aneurysm that way. Because aneurysms in the chest you can't feel. In the abdomen, sometimes you can feel, but you have to be really pretty skinny to be able to feel an aneurysm there. And it's usually just a happenstance that they happen to be found. We find some of them through screening programs too. People will get ultrasound screenings just to look for them as well. And so when aneurysms are symptomatic, that can mean they're leaking. And if an aneurysm is leaking and can rupture, the mortality rate's very high. So if they can be found ahead of time and they meet criteria for treatment, then we prefer to find them early.
Can the side effect of it be like severe pain, walking and leg aches?
Yes, you can have
The
pain.
aortic, right?
That's correct,
And
yes.
not the pulmonary one.
Not for the chest. Some people will get back pain or chest pain
Okay.
from the chest. That will occasionally happen. The vast majority of the time, though, pain in the chest is from the heart or from the lungs.
Right.
Yeah, it's unusual to be from aneurysm, but that's one of the reasons why if somebody comes into the emergency room with chest pain and the EKG looks okay and they don't have any other reasons to suspect, they get a CAT scan just to make sure it's not an aneurysm. Same thing with the abdomen as well. So the same CAT scan that can show you gallstones or inflammation of the gallbladder or problem with an abscess in the intestine can show you an aneurysm as well.
What's the stent made of?
It's a nitinol, so it's a metal scaffold of a springy wire, and it's lined with an impervious liner. In this case, Gore makes Gore-Tex, but there are some other companies too that make them that's impervious.
Is that the same thing that would be used if you have to open the artery?
No, if we had to open it, you do an open operation.
Well, no, I meant Sometimes the artery is closed, right?
Oh, right, yes.
Instead of a balloon, it's too narrow. Do you use
Right.
the same material? And
It's very similar. The stents are a little bit different because when we're fixing aneurysms, the stents don't have to have a lot of high pressure to push a lot of calcium out of the way. It's really just to decrease the blood flow. But they're very similar. They're just subtly different stents. That's correct. So transcatheter valves are valve surgery without a sternotomy and cardiopulmonary bypass. Again, right now there's no FDA approval for this, but there are several systems that are in development. And one of them is a core valve. So this is that stent, just like you saw, and it's got a valve that's mounted on it. So this thing would be pushed through the aortic valve after we did a valvuloplasty, that is, crunch all the calcium out of the way, and then implant this thing in there. So it's done without the heart-lung machine. It's done through a catheter, the same way that we do the aortic stent grafts. And so this catheter goes across where the aortic valve is, and the new valve is deployed in there. There are still some things to be worked out with this. One of the biggest issues is when we do an aortic valve replacement, we go in there and clean out all the calcium that's in there. We snip it out with scissors and bite it out with a ronger and clean it out very carefully. We can't do that through this system, and what is done here is a balloon is pushed in there and all that calcium is just crushed and smushed out of the way. The downside of that is some of the calcium can break off and go to the brain and cause a stroke. And so in the series that have been done thus far, the rate of stroke with this is up to 9%, which is really pretty high. Our stroke rate in our program is 1% per year. Nationwide, in most heart surgery programs, it's 2% per year. So there's still a significant difference between them. But in somebody who couldn't tolerate a regular heart operation, this is an option. That's right.
Is anything put in the carotids to try to catch the...
That's exactly right. So in carotids, they've developed these filters that can go up. You put a wire up and then we put a filter. I don't know if Dr. Jessup does in here, where they put a filter to capture any of that stuff. There's no filter that's been yet designed to do this, and in part because in the carotid you've got one artery going this direction and the blood flow is going that way. In the aortic arch, when you're coming around here, there are 3 or 4 major vessels that you'd have to block to try to capture that, and the umbrella's upside down. So as opposed to when you're putting it up in the carotid artery, it can go this way and you can pull it back out and pull the debris out. When you're going in the aortic arch this way, there's no way to really capture that yet, but people are working on that.
Is there any way pre-procedure you can determine the degree of calcification in the valve?
There is, but by echocardiography, you can tell.
And that would, I imagine, correlate to risk
Risk of
possible
stroke, right, but at the same time, that's the whole reason why they have the aortic stenosis too. So some people have very crumbly calcium and others don't, and there's no way to really quantify that.
Right.
The images for echo are pretty good, but they're not quite that good. Yes?
Does that mean you're not supposed to have a calcium food or anything?
It's interesting, there's not a big correlation between diet and the calcium deposits there. It's like, just like atheroma or hardening of the arteries everywhere else. It really varies from person to person, it's multifactorial. Some of it is diet, some of it is genetics, and most of it is we don't know.
What's the heart murmur?
So,
The valves don't completely close?
so the murmur is when the blood flow is not normal. If the blood flow is perfectly straight through a valve, it doesn't make much noise. Same thing through the carotid arteries here. If you don't have much blockage there, you very rarely have a brewing noise in your carotid artery. If there is turbulence to flow, that's when you hear it, whether it's in a valve or an artery or a peripheral artery.